Bommkanti, Aware Gleneagles Global Hospital, Hyderabad.
Hello everyone, I am Dr. Kalyan Bommkanti. In this video, I will explain you how to perform anterior cervical discectomy and fusion. It is a technically demanding surgical procedure. It is indicated for patients with cervical disc prolapse causing nerve root compression or spinal cord compression in the neck. This procedure requires good neurosurgical skills along with high-end equipment like neurosurgical microscope, high-frequency drill, intraoperative C-arm, fine microsurgical instruments. In this video, I will explain you the typical steps of this surgery.
The patient is placed supine on a radiolucent operation table. The head is extended by placing a neck roll underneath the neck. Skin incision. First, the level of disc prolapse and compression is confirmed using an intraoperative X-ray. Palpate the margin of sternocleidomastoid muscle. The skin incision can be taken obliquely along the anterior edge of sternocleidomastoid muscle or a horizontal incision just medial to sternocleidomastoid muscle. Horizontal skin incision gives better cosmetic results and oblique skin incision gives better surgical exposure and is much useful for multiple levels. Once the skin incision is taken, we use retractors to keep the cut skin edges separate. The platysma is cut perpendicular to its fibers. The superficial fascia and deep fascia are cut using microsurgical techniques. The tracheoesophageal groove is palpated and also the carotid artery within the carotid sheath. The carotid sheath also helps in identifying the tracheoesophageal groove. Retract the sternocleidomastoid muscle and carotid sheath laterally. Retract the tracheoesophageal complex along with the strap muscles laterally. In the next step, we will be placing Cloward's retractor. It should be placed very gently to avoid injuring the carotid sheath and the esophagus. The longus colli is swept laterally, exposing the anterior surface of annulus or disc space. Using a knife, a wide annulotomy is performed from longus colli to longus colli. Now the Cloward retractor is placed to retract the longus colli muscles. Annulotomy completed using knives. Casper pins are placed in the vertebral bodies and distracted to improve visualization of posterior disc space. Using straight and curved Caret's discectomy is completed. Using a high-speed neurosurgical drill, the base of osteophytes is drilled and then using microcurrents, 1 mm Kerrison rongers, the osteophytes are removed. A 1 mm Kerrison ronger is used to cut the posterior longitudinal ligament and free the cal sac. A high-speed burr is used to decorticate the end plates. This helps in improving the contact between end plates and the bone graft. A trail is placed to gauze the size of disc space. A bone graft which fits adequately into the empty disc space is prepared and placed into it. The bone graft is harvested from the iliac crest. The Casper pins are released to ensure compression of the bone graft between the end plates. Bone wax is applied over the holes in vertebral column after removal of pins. An anterior cervical plate is placed. Cervical screws are placed into the vertebral body. Hemostasis is secured, closed suction drain is placed and skin is closed in layers. For appointment, WhatsApp 85200033683. Dr. Kalyan, Neuro and Spine Surgeon.